G'day and welcome back to the Broom Docs and First 10 and EM podcast. And this is a very special episode because as opposed to our usual podcasts, which are purely audio, Justin has been visiting me in Perth doing some amazing lectures this week, and he gave a talk which was just too good to put in the audio format only. It needed some amazing video skills. So Justin's going to talk us through mastering diagnosis. Welcome back, mate.
Thank you. And luckily by video, it's still not our ugly mugs, just some slides. So that's good because we're going to do a little bit of math in this talk, but I like math being done in just like easy pictorial pictures. My kids too, we're not doing advanced trigonometry or anything like that. That's intro. Like diagnosis is pretty damn important. I think we both love the resuscitative part of our jobs, but really if you sit back and think about it, our jobs are really primarily diagnostic. That's what we do in emergency medicine. We see 25, 30 patients every single shift, and our real job is a diagnostic job. So I think this is really important stuff to master. And as we go through, the reason I found this so interesting is that there are so many ways that we get this wrong in pretty profound ways, in ways that I did not know about when I started medicine. So that's what we're going to go through, do a little bit of nerdy math together, which sounds right up our alley.
I love nerdy math. Let's move right on with some math to start. Down one.
So we're going to start outside of emergency medicine, because I think the problem is when you do cases inside of emergency medicine, we already have a sort of idea of how all the tests work. So we're just going to do very straightforward diagnosis. This is an asymptomatic patient, so somebody who would be in a GP office. This is Robin. She's 45 years old. Her friend got diagnosed with cancer, and she comes to your office just wondering, do I have cancer? And as luck would have it, your hospital just bought a brand new MRI machine, and so you have a brochure sitting right there on your test. So we rarely know this, but in this case, we know perfectly, 99% sensitive, 95% specific. We know, it's an MRI. It's a great test. And of course, what happens is your heart drops and Robin's got a positive test for cancer. And so the question that I raised here is, what are Robin's chances of having cancer? What do you tell her? You're a clinician.
Well, you read the bottom line of the report, Justin, because it says there is a tumor in the breast, so that must be right. Is that right?
That's what I've done forever, because it's an MRI. You just read the bottom report. That's what you do. At this point in the talk, we realize that I'm a jerk, because actually you do not have enough information at this point to figure out what the hell to do. And I think the important thing that we're going to go through throughout this entire process is you have to know the pretest probability in order to figure out what's going on with any test. Tests are not standalone. You need to do a little bit of math to figure out what they are. And so we can fill you in. Somebody in their 40s has an incidence of breast cancer of 1 in 1,000. She didn't have any symptoms. So now you have all the information you need. Now you've already seen this talk, but are you able to figure out what her chances of having cancer? Like, what do you tell her?
No, well that's the thing, is I think that intuitively we all think that something like an MRI just seems to be a very potent test, and it must make it very likely that she has cancer. And that's the intuition that we all have. And I guess the same thing goes for emergency medicine, for example, when we see an incidental on a CT. Like a CT it's kind of hard to overwhelm a CT, but your patient didn't come in for that particular problem, but same sort of scenario, yeah.
Yeah, I would have said it's not perfect. Right? I'm seeing that 99% sensitivity, but like in medical school, I wouldn't have been able to tell you whether it's the specificity or sensitivity, but I would have told you like there's at least like a 95, maybe a 99% chance that she has cancer. I would have said something along those lines. Turns out the real answer is 2%. There's only a 2% chance that Robin has cancer. There's a 98% chance that we're wrong. But I think everybody would have done what both of us have done in the past, which is just read that final line and say, hey, you got cancer.
Yeah. And it's kind of hard to sell, but that's almost a good news story, because her risk has almost not gone up whatsoever. And she should walk out of the office happy. But humans don't work that way.
No,
when we see a report like that, we think this is bad news.
MRI says cancer. It's awful. And so that's so shocking to me. That the reason I put this talk together was I wanted to do the math, because I think to be great at this job, we really need to understand how to do it. Now, don't worry, we're not going to do any formulas. What we're going to do is we're going to do the math with pictures. And don't ask me how long it took me to get exactly 1,000 black dots on the screen, but this is exactly 1,000.
I have counted them. Yes, there's 1,000 there. I can vouch for you.
And so we know her incidence or the risk of having breast cancer for a woman in her 40s is 1 in 1,000. So we get one little red dot.
Yep.
And the test MRI was 99% sensitive, which means it's almost certainly going to cause that find that dot. So we don't have to worry too much about that. But the problem comes in with the specificity, and it was a good test. It was 95% specific. Yeah, better than almost anything we order in emergency medicine. But it still means out of these 999 healthy women, there's about 50 false positives.
Right.
And just looking at it, we can get a sense of the issue, because at the end of the day, we end up with 51 positive tests. Only one of them is a true positive, and obviously you don't know which one is Robin, and so her actual risk is 1 in 51, or about 2%.
Yeah. So that makes total sense. So we've moved it from 1 in 1,000 to 2 in 100. Still a very low number, but as you say, is that enough to get us over that threshold where we're actually doing this patient any good? I don't know.
Yeah, this example was mind-blowing to me when I first saw it, because, again, this test is way better than any of the tests we send in emergency medicine. Like, none of our tests are this good, and yet a positive test, we're wrong 98% of the time. Like that, like, how is that even possible? That was never taught to me. That's not how it works.
And to put that in context, 99% sensitive and 95% specific, compared to most of the tests we do in the ED, which are generally, depending on which way you go, but most imaging tests are sort of in the 90s for sensitivity and sometimes high 80s or something for specificity, so nowhere near as good as this MRI machine.
Yeah, and I won't bring, like, a stress test has less than 50% sensitivity. Like, we won't even get into this kind of realm. But, like, look, this is an emergency medicine, obviously, so hopefully people aren't too turned off. Let's do an emergency medicine example.
Love it.
And this came up in my group text chat just the week before I came down to Australia. It's the great catch. And I think it's important for us to talk about our great catches, and I'll never fault anybody for bragging when our jobs are so hard. But in this case, it's a patient who is PERC negative, but for whatever reason, a CT scan got ordered anyway. And we'll ignore the fact that almost all of these patients are so low risk, the CT scan is going to be negative, so it's just a waste of time. And in this case, this is the one that is CT positive.
Damn it.
Yeah.
Yep.
And it's the one that you will hear bragging about, right? It's handover and the teaching to the registrars, seeing as I'm in Australia, the residents, whatever it is going to be, is that PERC is fallible. You can't trust PERC. You got to trust your gut. And, the question is that the lesson? And you got a foreshadowing with the last case, but we'll do a little bit of math. And, PERC is not a definitive rule out. If you're PERC negative, you have a 1.4% chance of having a PE. That's just how PERC works. And so maybe your colleague is great. Maybe he caught that 1 in 100 needle in a haystack, right? Great. And a CTPA, it's really hard to get great estimates on this. So I think these are actually overestimates. I rounded up to be sure. But it's a pretty good test. 95% sensitivity, 96% specificity. It's pretty good.
Still not quite as good as Robin's MRI, though.
Not quite, which gives you a little bit of a hint of where we're going here. So let's just do that math again together. So 1,000 patients, 14 who are PERC negative are going to have PE. That's just how PERC works. 95% sensitivity means that we're going to catch 13 out of those 14. So that's not bad at all. But the specificity, again, is where the problem is. It's, what did I say, 986 healthy patients. And at the end of the day, we ended up with 38. Where did I go?
So 13 were true positives.
Yeah.
There was one false positive. Oh, sorry, one false negative, I should say. And then you had 50 odd that were false positives, essentially.
Yeah. And so at the end of the day, you end up with 52 total positive scans, and only 32 of them are true positives. And so the chance that this patient actually has a PE is only 25%.
Yep.
And again, that's pretty shocking to me, because this is a CT pulmonary angiogram where the bottom line report says it's not like clinical correlation required. It just says pulmonary embolism.
Yep.
And there's only a 25% chance. But the reason this is really scary for me is, at least the cancer patient, you have a sense that somebody else will fix this problem for you, right? There'll be a biopsy and somebody will catch this along the way. These patients will all just get the label of PE. We're done. We're done the diagnostic workup. They will all get put on anticoagulation with all of the harms. But there's a 75% chance that we're wrong, and we're starting them on a pretty dangerous medication. 75%. We're not talking about, when we talk about missing PE, missing MI, we talk about like 1 in 100 we get worried. There's a 75% chance we're wrong. That's dramatic.
Now, I remember when you gave this talk, the other confounder with this is that if you ask 6 different radiologists to look at that same CT, you may get 4 different answers depending on the way that they read it, because especially when you get to the smaller end of the spectrum of PEs, there's a lot of gray zone in terms of reporting and the threshold for calling a positive as well.
Yeah, so this sounds pessimistic, but actually I think you're right. I think this is an overly conservative estimate, and the number is probably even worse than this. It's not even a 75% chance we're wrong. It's maybe 80, even 90. It's so scary. It is so worrying to me. And so we talk a lot in the talk about this. The key is that to be a great diagnostician, you can't just read the CT scan report. You got to know the pretest probability. And we made the comment that to be a great diagnostician, you don't actually make definitive diagnoses because we live in basically a world of probabilities. There's no 0%, there's no 100%. And so that brings us to this system. And we're going to go through a bit of a mathematical system to try to help us understand tests a little bit.
Cool. And I will point out that it was the amazing Dr. Simon Carley from over in Manchester who I think coined the phrase probabilistician rather than diagnostician way back in the first SMAC sort of 10, 12 years ago. So, yeah, this is something that we've known about for a while, but it's taken a while to catch on, this idea that we work in probability.
Yeah, and I'm hoping the PE example really drives it home because I know a lot of people find this annoying, right? Like we just want definitive diagnoses, but I think you can really wrap your head around the significant harms that come from not understanding this. So even though it makes our jobs a little bit harder, I think it's so important for our patients to understand the dramatic. Like we're not talking about 1% misses here. We're talking about being wrong more often than we're right. Like this is dramatic.
All right. So talk us through the system, Justin. It looks very complicated. You've got 0 on one end and 100 on the other end and arrows in the middle. Let's go.
Yeah, so I think the question is, so if a test doesn't give you a definitive answer, what the heck is the test actually doing? And I tend to just picture tests as arrows in my head. So they move you a little bit in one direction or another. And, some tests most of our tests are not very good. They're little arrows. And we can talk about a white count or a urine dip or whatever. They probably are smaller than that arrow that I put there. But obviously we have some really good tests as well. A CT showing a pneumothorax or your end-tidal CO2 for tube placement are good tests that move you a long way. So we can have any sized arrow that will move us around this screen. I do point out, if anybody likes listening to their classic Greek, Zeno's paradox, you can't get all the way to 0. You can't get all the way to 100. So that's really important to keep in mind. There is no absolute certainty, but these tests can get us pretty close if we pick the right test, and they sort of move us up and down the spectrum. And I think this is really important because it helps us explain a little bit why pretest probability matters so much, right? You can't figure out where you end up if you don't know where you started. And so this just shows, we already talked about, if you're PERC negative, a CT pulmonary angiogram only moves you from that 1.4% starting point up to about 25%. That's not great. But if you start further up the scale, the CTPA looks a lot better. So the example I give is a Wells score of 4. So a moderate risk Wells population tends to have a pretest probability of about 28%. And a CTPA will move you way up, where absolutely I'm comfortable anticoagulating you. Unfortunately, though, not 100%. So a positive test, a positive CTPA still only leaves you with a 90% chance of having a P. There's still a 10% chance you're wrong. So there's you always have to be really careful with our diagnostic tests. And if things aren't fitting together, always be open to second opinions. Always be open for repeat reads. But the key point of this slide is just where you start. The key point of this slide is where you start influences where you end up. These arrows really help you understand why pretest probability matters so much.
Now, a little anecdote I'd like to share, Justin, just because I spent a bit of time in Ireland as a young trainee, and one of my favourite anecdotes from my experience in Ireland was stopping on the side of the road to ask for directions, and this old Irish guy says, well, if I was you, I wouldn't be starting from here. And I think that's a really nice anecdote because often you get cases that are presented to you as a boss in the emergency department where the doctor has taken a history and there's really no good pretest probability that suggests that you're going to go in any direction. So I think what you're saying here is that if you're starting at a really low pretest or a really murky pretest, the thing isn't to order the CT just to blunderbuss try and diagnose, because we're not going to get to where we want to be, but to try and get more information so that you can work out what is the true pretest probability, so that you can actually make a rational decision.
Yeah, I mean, sitting with you in the ultrasound office for the last couple of days, I think that's basically your entire job is people requesting ultrasounds, and you're saying, no. What is the pretest probability here? When you start with 0 pretest probability, we run ourselves into some problems, and I think a lot of medicine has 0 pretest probabilities. So at this point, we need to figure out how big the arrows for our tests are, because we already talked about this. There's little arrows, there's big arrows. We're going to leave out a broader discussion about how bad sensitivity and specificity are. We can put a link in the show notes. I have an example on a blog post on my website that shows you they just don't mean what we think they mean. And so
Yeah, and I think we've talked about this ad nauseum on the podcast, but sensitivity and specificity are, in and of themselves are fun and they get reported. But over the years, we've seen better and better papers starting to describe the likelihood ratios. And they're just a product of the sensitivity and specificity at the end of the day. But someone else can do that awkward math for you because these are much more useful numbers to carry around in your head.
Yeah, I think there's a lot of ways that the sensitivity and specificity could mislead you. And if you actually just look at the formula, you have to know whether the patient has the disease or not in order to interpret it, which is obviously a little bit ridiculous. So what you really want to look for are likelihood ratios, because actually likelihood ratios literally are what tell you the size of your error. That's what's going to give you the idea of how far your test is going to move you. And the basic concept is super easy, right? You take your pretest probability, you multiply it by a likelihood ratio, and you end up with the post-test probability. The math I would not recommend doing on your own, because unfortunately it uses odds, and unless if you're spending every weekend at the betting on racehorses, maybe you know how to multiply with odds. But for the most of us, the math is hard. But luckily, it doesn't matter. We don't need to know the specific numbers here. They're just the general concepts, because we all know multiplying by 1 does nothing. So if you see a likelihood ratio of 1, that tells you the test is absolutely useless. And the closer to 1 you get, the worse a test is going to be, and which gives you the sense of if you have a very big positive likelihood ratio, that's going to move you a long way because you're multiplying by a big number.
Yeah.
And if you have a very small decimal for a negative likelihood ratio, that's going to move you a long way because you're multiplying by a very small number. So a pretty simple concept, honestly.
Yeah. I think my 9-year-old was explaining it to us at dinner the other night. So, yep, if he can get it, you can definitely get it.
Yeah, absolutely. And so it's just a matter of getting a little bit of comfortable or familiarity with how far these move us. And the vast majority of our tests are sort of in a 2 to 5 range on a positive likelihood ratio, which I think we all have a gut sense of how that works, although we make mistakes in the heat of the moment. So like a chest x-ray in CHF has the likelihood ratio of just under 5. And we all know, it increases my likelihood that this is CHF, but it's not like I'm hanging my hat on it. I wouldn't bet my home on whether that was truly CHF. So, we know not to completely trust it, but it's okay.
And I think that's, you alluded before that I sit in the office turning declining scans all day for ultrasounds, but we know that most ultrasound, for example, has that likelihood ratio in that 4 to 5 range in the positive direction and maybe not as good in the negative direction. So you really got to be starting at a good place clinically before you do the ultrasound to really get over the line.
Yeah, and we'll get back to some examples of that in a moment. And then you'll hear, I hate the terminology. A lot of people will say once you get above 10, that's where you're getting into the quote-unquote ruling in. Above 10 is definitely a good number to look for. A CT pulmonary angiogram has a positive likelihood ratio of 18. So from our examples already, you can see for sure it's not ruling in, but it is a good test. It moves you a long way, but where you start still matters a whole bunch.
Absolutely.
And then the opposite is just true. The number you're really looking for is less than 0.1 for the negative likelihood ratios, but similar idea.
And in emergency medicine, I think it's important that people think about what sort of tests they're doing. Generally, when we do imaging tests, we're usually trying to rule in a diagnosis. That's usually what we're doing. And most of our blood tests that we rely on, and specifically thinking about things like troponin and D-dimer, we're trying to do this in the negative direction. So a lot of the things where we're trying to exclude bad diseases, these are the tests that we want. And those are deliberately set. High sensitivity assays are designed to do this for us. Yeah.
Yeah, and that will lead us into an important topic next. What we'll just say, I don't think you should be doing this math by yourself. In the old days, they used this funny thing, the Fagan nomogram, where you just put your dot on one side, draw a line through the likelihood ratio, and get your answer on the other side. Honestly, just Google it. There's tons of calculators out there. But now that we know about these arrows, I think this leads into exactly what you were saying. Is we can use them to help us visualize and explain some of the more common diagnostic mistakes that we all make. And I think the most common one, which you were just alluding to, is that some of our tests have dramatically different arrows in different directions, and it's easy to think about that. So massive arrows to the left and none to the right. And I think we all know the D-dimer, for example, would be a great example of this.
Yep.
But for example, if you have ever ordered a CT scan just because somebody's 72 years old and they bonked their head, you are making this mistake. If you look at them, they have no symptoms, and you're like, yeah, I don't know, they got like a 1 in 1,000 chance of needing a neurosurgery head bleed, but they don't pass the Canadian CT head rule. Look, that CT head rule has a great arrow to the left, but none to the right. So if they were 1 in 1,000 before the rule, they're basically still 1 in 1,000. It might get up to as high as 2 in 1,000 after the rule. You don't order CTs just because people failed rules. That's not how these rules work, and this is the reason right here. This is the reason I'm willing to ignore a D-dimer that was sent by another clinician before me when I go back and talk to the patient and there's just no chance they have AAP. This is the reason you're willing to ignore a lot of tests, because a lot of them have dramatically different arrows in different directions.
That's really important. And I think that in emergency medicine, that's a really hard concept, because when you see a positive test, we see those little red arrows flash up on our EMR next to it, and it's really hard to ignore that. But you do need to go back and what I call unstuff the turkey. You need to think, what was my pretest probability? What does this arrow actually do? And if it's not moving you anywhere, then you've got nowhere, basically. You've gone around a roundabout. Yep.
Yeah, and we'd probably need to get better at talking about this for more things, because even in my personal part, I'm very comfortable ignoring D-dimer, because we've all talked about that for so much. But you get that positive lactate that just makes you feel a little bit more nervous about the patient. But we know it's also an awful test, but it's just a little bit harder to just send somebody randomly home with a positive lactate, even though I know it's a false positive, right?
Oh, don't get me started on the repeated false positive lactate, where the first lactate was 2.3 and then the next one's 2.7. So the patient ends up spending the whole day in the department having lactates for no benefit.
I think another great thing that these arrows might help us understand is when different tests point in different directions. And I'll use some decision rules. People may know how I feel about that in general, but what do you do in this situation? So you get a young lady rear-ended, but she managed to hit her arm against the side of the door. So she ends up with a humerus fracture, but she was able to get out of the car. She is able to sit up on the stretcher. She's sitting there talking to you, normal vital signs, no neurologic symptoms. So if you go through, she can move her head 45 degrees left and right. So she passes the Canadian C-spine rule. But when you feel her, she is a little bit tender in the midline, and she's got a humerus fracture, so she's got a distracting injury. So she fails nexus. So what do you do when you have two different rules that tell you two different things?
So this is a really cognitive dissonant moment, because you've got a patient where you're thinking, they could have a really bad disease. Like, I don't want to miss a broken neck. I've got one rule telling me one thing and one rule telling me another thing. And there's nothing funny about a humerus fracture. So, what do I do?
Oh, this is now clearly the Broom Docs podcast at that level. But I will say your kids tell better dad jokes than you do, but we'll move on. So I think, honestly, in my experience, most people in North America would probably order imaging in this case, right? They fail the rule, you go on to imaging. And I think the arrows really help us understand why that is entirely wrong. And so if you look at all comers in major trauma, their risk of having a C-spine fracture is about 2%. And the nexus rule does have an arrow to the right. It's not a very big one, but it has an arrow to the right. So if you fail nexus, you go up from 2% to about 3%. But the arrow to the left on the Canadian C-spine rule is so huge that it doesn't matter if you started at 2% or 3%, or we could go significantly higher. You still end up as close to zero as humanly possible. So the asymmetric arrows explain why you 100% in this situation, you rule out despite failing nexus. And I think that's so important to understand.
Yeah, that's really useful to sort of visualize it that way, and just remember that asymmetry, because it gets you out of a lot of trouble and can really make it good for communicating with patients as well.
There's a last topic that we have to discuss briefly to round out this whole mathematical system, because as we said, our tests don't give us definitive answers. And so if they don't give us definitive answers, how the hell do we know when to stop testing? Because we're just moving up and down this scale forever. And the key is that our tests cause harm. And I think it's really important to recognize whenever we talk about harm in medicine, we tend to really focus in on things like radiation and stuff like that. But that's not the big harm of our tests. When we're using them in the wrong populations, our tests give us wrong answers, and that's dramatic. And so when you look at this harm, when we're talking about harm, you got to think about that PE example every single time. When we're wrong more often than we're right, and we just don't even know it. That's the dramatic harm here. And so this this area down at the bottom of this test threshold is labeled as harm, you truly are. We're not talking about cost or inefficiency. We're talking about situations where you're actually hurting your patient to order another test.
And my understanding is that when Jeff Klein developed the PERC rule, he came up with this number of whatever is 1.4%, and he structured the test and looked at the derivation so that he could work out when they were crossing that threshold. And it's very rare with decision rules that someone's actually done that, as you've mentioned.
Yeah, it's so important, and we haven't done it nearly enough in medicine to figure out exactly where these test thresholds are. I'm not so concerned about the numbers, although I think we'd be great if at rounds we actually spent a little bit of time calculating these and thinking about the numbers a little bit. But I think the important thing to keep in your head is that your tests can cause harm, and the harm is from misdiagnosis. We don't think about that. We think that our tests are always going to make us at least a little bit more accurate. We may understand that they're not, perfectly accurate, but tests in the wrong population can actually lead you completely astray. And that's the thing. So we need to stop when the patient's chance of benefit from a test is under their chance of harm from that test. And that's what the threshold tells us. And I'll just point out that there is a threshold at the exact opposite end that we tend to ignore all the time. We're always looking at low-risk patients, but high-risk patients also have a threshold because it's really bad to add extra tests when the patient is already up in the realm where you should just be treating them, right? When the patient going to the ICU clearly has a pneumonia, if you're waiting on the x-ray before giving them their antibiotics, that's silly. And the example I use is that we do this implicitly. We just never label it as a treatment threshold is in STEMI. You got a chest pain patient, you got a big STEMI. Does that mean that they for sure have an occlusion of their coronary artery? No, you'll get clean casts 10 or 20% of the time, but we understand that that diagnosis is important enough and treatment is important enough that the ECG is accurate enough to do that diagnosis. But I think we make this mistake in so many other conditions that we just keep adding tests when we should just go ahead and treat.
Yep, the quest for total certainty in order to get past. But we'll talk a bit more about how these thresholds move with different disease states as well.
Yeah, so I think in a general concept, it's worth knowing that the thresholds are not set. And so if you have a really dangerous condition, you're going to have much lower thresholds because you want to catch more patients, but also at the top end, you just want to go ahead and treat. It's a dangerous condition. But if you have a benign condition, who cares? Set those thresholds higher because you don't need to find that many people. The part of the whole threshold calculation that I really like to emphasize that we overlook is that accuracy of tests really influences these thresholds. So if you have a super, super accurate test, you can use it in more people because you're less likely to have these misdiagnoses that we have. But the less accurate your test is, the less you should order it. And we sometimes talk about that in emergency medicine. We know we shouldn't just be sending a D-dimer on everybody because it's going to screw us up. But stuff that is called routine blood work includes things like a white count, which is the least accurate test that we have in all of medicine, but people refer to it as routine. So we clearly don't fully understand the test thresholds. Inaccurate tests should be sent as the most infrequent tests that we have.
And I'm not going to go on too much, but the humble CRP probably comes into that category in that it's a test that is almost ubiquitous in emergency medicine, but really doesn't do a lot in terms of moving our patients in. And we're generally sending on diseases where they're not super bad diseases. They're looking for things that might be cause a little bit of problem, but we send them way too often, and I think we way overvalue their value in the diagnostic sliders that we're talking about here.
So let's try to make this usable, because up until this point it's been incredibly mathematics, and it doesn't seem like something you're going to do on any clinical shift. But I don't think. I actually think we should be talking about these test thresholds, doing a little bit of math in round settings and things like that. I think if you really want to get good at this, go on websites like thennt.com and play with the sliders and get a sense of what the likelihood ratios are. But I think a qualitative approach is more than good enough to make sure that we don't make the massive mistakes that we made with Robin or with that CTPA case at the beginning. And so my qualitative approach is to take any patient and to put them into one of 5 general pretest probability categories when I see them. And so the slide here tells me the first question with any patient is, do I need any tests at all? So are they in the really low risk or the really high risk categories, i.e. below the test threshold or above the treatment threshold? And if they're there, stop. No testing is needed at all. Either at the low end, just do nothing, or at the high end, just start them on treatment.
And there was a fantastic slide that came out the other day that I think I shared with you on Twitter, but it's doing these tests is like picking your nose in public. You got to know what you're going to do with the result before you do the test. So you need to contemplate this a little bit. And if you get a test that's not actually going to change anything because you've already decided what you're going to do, don't go digging.
And let me emphasize before we move on to the other categories, I think everybody always talks in testing about the big tests like CT scan, but at the high risk here, this includes simple things like UTI. Yep. If you have somebody with a classic UTI, they've had them before, this is my UTI, and they have none of the other risk factors, no vaginitis symptoms, no sexually transmitted infection symptoms, they're in that red zone. Just put them on the antibiotics. But I think a lot of people add a urine dip or a urine culture in that situation. But the problem is the urine dip is an incredibly inaccurate test. So if the patient clinically has a UTI, but you let a test with an 80% accuracy talk you out of treating them, you're doing them harm. We need to get a lot more comfortable just treating clinically and say, yep, this is accurate enough. I'm going ahead.
And we talked a little bit before about how bad diseases you need to be have those thresholds more set higher. And so there's a big difference between the young woman that's come in that's just been on a honeymoon recently and has some urinary symptoms versus the patient that's coming with urosepsis. Like in that patient, you really want to get the disease right and you want to get the antibiotics right. And so that's fine to send the dip and culture and everything. But for the young woman that's going to get better no matter what we do, probably no antibiotics will probably work for a lot of those women, but we can send that person home knowing that they're going to get better no matter what happens.
Yeah, we can conflict that the quality of the treatment matters as well as the harm of the treatment, right? For me, giving out a little bit of amoxicillin is not the end of the world when it's got a good chance of working, but like I'm not testing people for COVID because like Paxlovid does nothing, so I don't really care. So it's a good qualitative approach, but you have to adjust the thresholds for each condition in your mind. And again, this is why we need to talk about this stuff at rounds a little bit more, so we all come in and have reasonable thresholds. So the first two categories of people in this 5-category system are the people who really don't need to do any tests at all, and this is probably more patients than you think. But then everybody else is going to be in the middle. These are all patients who need tests, but I think before you order the test, you have to have an idea of what the risk is. And so I try to put every patient into one of 3 categories. There's the unlikely patients down in this, 10 or 20% range, the likely patients up at the other end at like the 80 or 90%, and then the ones who, if you have diagnostic acumen like me, is like everybody, I don't know, just completely in the middle, I have no bloody clue, 50% range. And then once you know what category they're in, now you can pick the test that actually applies to them. This is so important because not all tests are valuable in every single situation. Now, I'll say a few things about tests. First of all, there are some tests that don't move you at all, right? There's too many tests where you order the test and at the end of the day, you're in the exact same category as you started in. And I think way too often in medicine, we have this approach here, which you just referred to with your picking the nose analogy, but we ready, fire, aim. We fire. Yep. We order all the tests, and then only after the fact do we aim and figure out what we're going to do with them. So think about what you're going to do with the test before you start firing off those tests.
Yep, and we mentioned this in the talk in the lecture, but the structure of modern emergency medicine, there's so much time pressure is that we love to get all the tests from the lab, for example. They're going to take an hour to come back. We want to get them done up front, but you've really got to think about what you're doing by doing that because it can create a lot of harm, unfortunately. So, unfortunately, I think that's part of our culture nowadays, but it doesn't mean that you actually have to do what the test thinks that you can still use this approach.
And then, as I said, so you're just going to try to pick an appropriate test. Way too many of our tests, a urine dip or things along those lines, do not move you out of the category you started in. So don't order the bloody test. I think the one rule about tests that I would love to burn into people's minds with this system is that the vast majority of your tests will at most move you one category in this system. So when I look at this graph, I'm picturing a patient with significant shortness of breath, but I'm on the fence between COPD and CHF. I think it's CHF, but not enough for me just to admit them and start treatment right away. So if I order a chest x-ray, a positive chest x-ray will move me up one category. Boom, I'm in the red zone. This is CHF. Admit them, I'm done. The mistake we make is with the negative test. Too many people look at that x-ray and be like, oh, it's not CHF. But really, you've only moved down one category, and you're just in this completely...
Back in the gray zone.
Yeah, who knows? But it's not low risk. It's just 50-50, who knows?
Yep.
So you're going to need some other test. I think we need to be very cautious with how we phrase that. Not every test is something that you write down on a piece of paper. So this test might just be observation for 24 hours. It might be a trial of treatment. But the mistake is thinking that you've moved by more than one category with that chest x-ray. Too many people, I say, oh, well, it can't be CHF. The x-ray looks fine. No, if you really thought it was before the x-ray, you're still in the complete gray zone. Now, if you had started in the opposite green zone and you were just ordering the chest x-ray to quote unquote rule out CHF, yeah, moving down one category might be enough in that zone. So where you start really matters. But if you had the general guideline that tests only move you one category at a time, man, it's way less likely we're going to make that massive mistake that we did with PE at the beginning.
And the concept I really love there is not all tests are tests as we think about them as well. And I think Damien Rowland points this out, that the best test you could do for a febrile baby is an hour of observations and just watching over an hour and seeing what comes back, because it changes your sliders mainly only by one category. But if you weren't too worried before and their obs completely normalized, after an hour you could be below that threshold where you can say to the parents, that's fine, you can go home. But the opposite may not be true. You may still be in that uncertain zone if their obs are still abnormal in an hour, and then you know where you are at least.
Yeah, I think everybody in the generation before us knew that the best test in medicine is time, right? Just uncertainty just melts away because symptoms change and develop. But the time pressures of modern medicine mean that we don't use that time test nearly well enough.
Maybe that's why my ultrasounds are so good, Justin, because it takes me an hour to do an ultrasound. So by the end of that hour, the patient's declared themselves, and I can write that in the report.
most of our tests, again, if you just went away with the lesson that all tests move you one category, I think we'd be okay. There are tests that move you two categories. I think the caveat that I wanted to throw on here, this is mostly going to be CT scans in the context of emergency medicine, but some of them can move you two categories in one direction, but zero in the other. That's the asymmetric tests are one that to keep in mind. But I think looking at this graph is really important, because the best tests are going to move you two categories. Tests are not going to move you three categories. And I think that's really important to note, because if you start in one of the green zones, so if you have a low risk patient for any disease and you get a positive test, you're not going to move three categories. So it's very unlikely that you move all the way up into the red zone at the opposite end. There are many times in medicine where you have to order more than one test or do more than one test. That could be that time and repeat observation in order to convince yourself that the disease is truly present. And I don't think we do that enough, which is why we have, I think, an endemic of false positives and overdiagnosis in medicine in the modern day.
Cool. Yeah, that's really useful. And so I think just picturing that and just being familiar with those zones, and I think that's something that, we could almost make up a little abacus slider and keep it on the flight deck that we can use for discussing with our residents, just to show how much these things are moving, because I think that's something that's really hard to get a sense from reading papers, just getting that visual sort of understanding of how much potency each of our tests have and what it actually does for our decisions in emergency medicine, because we're training people as binary decision makers, and I love this system because it really helps people come to that subtlety of diagnostics.
Yeah, and as I said, I think this qualitative system is good enough. If you can keep this in mind, if you can remember, A, that our tests can cause harm and lead to misdiagnosis, so really keep an eye out for the times when you're outside of the thresholds, and B, that most of your tests are only moving you one category at a time, that general approach is going to avoid the big mistakes, that time when we're wrong 75% of the time we think it's a PE and it's not. So most of the time we're not pulling out a calculator on shift. Like that's just the honest truth. But I do think if you are finding yourself in these situations where you think that like I'm moving two or three categories, those are times when it's not unreasonable to actually pull out the calculator, look up the likelihood ratio, and make sure you're not making a big mistake. So if once out of every two or three shifts you actually do a little bit of math, I think you probably are actually going to end up helping your patients in the long run.
Can I just ask you, Justin, do you have any good resources for where people can find these numbers? Because obviously you can go back and read the original trials and calculate it, but is there any other good resources?
Yeah, so the two that I go, they haven't added a lot recently, but the NNT.com, there's two sides to that site. Almost everybody knows about the NNT site, where we see the evidence for any of our treatments, but there's a flip side to that which contains a ton of likelihood ratios, and I love it because there's some sliders, so you can change your patient's pretest probability at the top, and it'll tell you exactly what their post-test probability is. And I think you can really build your diagnostic intuition about how good various tests are and how patients move. The other, and I don't know that I'm going to have the exact name of the textbook off the top of my head, but Chris Carpenter is one of the best evidence-based medicine guys out there, was the editor on, I think it's just called Evidence-Based Emergency Medicine. It is a textbook, but it specifically does this. It looks through all the literature and tells us for all of our tests, here's what the actual likelihood ratios are, and it's a fantastic resource.
Yeah, and I think just getting into the practice of using this sort of visual cue on your shift, if you don't practice it, you'll never learn it. And the more you use this stuff, the better you're training your brain to understand what these tests are doing for us and hopefully making better decisions.
Yeah. So I think that's it. I think my takeaways from this talk are pretest probability matters a whole bunch. Our tests can cause harm, so we have to remember those likelihood ratios. We don't make definitive diagnoses. We live in a world of probability. I think those are the three big ones. I think the one thing that we didn't say throughout this, which in my mind is implied, but maybe it's not, and we should make explicit, is there's so much uncertainty in all of this. There's not just we're talking about living in a world of probabilities, but obviously, I don't know if the pretest probability is really 2% or 3% or 5%. It's all a little bit fuzzy. And so with this much uncertainty, it really emphasizes the need for the best tool in all of diagnostics, and that's shared decision making. Talk to your patients, involve them. That is so dramatically important when it's no longer a world of black and white, but a world of gray.
Yeah, and I think that's something that we often forget in emergency medicine, is that we look at the patient, we do the test, we decide what the diagnosis may or may not be. But at the end of the day, the patient is the one that carries the risk, and they're the people that actually have to go through the treatment or take the anticoagulants or have the operation that our tests are saying that they should do. And there's a spectrum of patients as well, and that some patients may be happy to accept a 2% miss rate on their chest pain workup, whereas others really want a 1 in a million chance that they don't have a STEMI. And so you do need to go to the patient and work out what their own personal thresholds are. And, obviously we try not to be too paternalistic in medicine, and we can sort of make the numbers whatever we want them to be. But I think you do need to involve your patient, particularly when you're around those fuzzy grey zones at the edge, and the 95% confidence intervals in a lot of our tests are a lot broader than we would like to admit.
Yeah, this was a theme in the main presentation that we sort of cut out here, but I think the point of our getting together and talking about this now is we're not very good at this math right now. I think everybody, and myself included, we all need to get a little bit better at this math stuff. But at the end of the day, diagnosis is still a human pursuit. We're here not just specifically about the diagnosis, but also about the needs, the desires, the anxiety. We're not looking after a chest pain. We're looking after a person who is scared as hell about their chest pain. And so at the end of the day, if it's just this math, if that's what diagnosis is going to be, if diagnosis is about getting the right answer, quote unquote, we're going to get replaced by AI very, very soon. So if we don't want that to happen, the goal is you need to learn this math, because we need to stop making these dramatic errors that we've been making. The PE, we're wrong 75% of the time, but we need to learn how to translate this math into really good advice for our patients.
Yep. That's an awesome point to take away, and I think we can wrap it up about there. So thank you, Justin, for joining us once again on the podcast, and thanks for all of your amazing lectures this week. And we'll hopefully get some feedback on this, and maybe you and I can get together and start chucking up some numbers on the website so that we can create another resource which people can use to try and hone their mathematical diagnostic skills.
Pleasure. Take care, man.